So what we'll do now is to examine reflexes. Now, reflexes can be extremely helpful in neurological examination, and sometimes they can be a little bit misleading. So every patient, you have to put what you find into context. And sometimes in very well muscled and fit individuals, paradoxically their reflexes are very difficult to elicit. So we'll start with the biceps reflex. So you need to put your finger on the biceps tendon and give a firm tap, and if you look carefully you can see a twitch of the muscle and a movement of the forearm. So that's the biceps, which is C5. Reflexes can be brisk in spinal cord disease, they can be absent in nerve root disease, and between those two extremes there is a variation of normality. So we'll look now at the supinator reflex. This is C6. Again, we're looking for a twitch in the muscles here in the forearm, and you want to do a firm blow to the radius, and you're looking for both a movement of the muscle and a movement of the arm. Sometimes patients who have upper motor neurone signs with spinal cord disease, when you hit the supinator reflex, you'll see a flicker of the fingers, and that's something to look out for. We'll now do the triceps reflex. Again, you need to be feeling the triceps tendon, which runs down to the olecranon process, and give it a firm blow. And you can see there both the muscle twitching and the forearm extending slightly. So Tom's reflexes are within the range of normal. So if the reflexes are all absent or all reduced, then that gives you a very different picture than if you find one reflex missing. And if you find one reflex missing in a patient with neck and arm pain, then that can help you localize the level. So if it's the supinator reflex that's missing, that's predominantly C6, and we would know that the C6 nerve root might well be involved in the causation of the patient's arm pain. If the triceps reflex is absent, then that's predominantly C7, and we'd be looking for a problem associated with the C7 nerve root. So, having covered the myotomes and reflexes in the arms, we can now use a pin to map out any possible sensory loss in the dermatomes. So if you get your patient to put their hand into the anatomical position and then start in an area that you suspect is normal. Tom, do you feel that as a sharp pin?
Yeah.
And then start examining the dermatomes, starting with C4. Do you feel that sharp?
Yeah.
C5.
Yeah.
C6.
Yeah.
And C6, remember, comes down onto the thumb.
Yeah.
C7 is the ventral aspect of the forearm, coming down onto the middle finger.
Yeah.
C8, which is the medial aspect of the forearm, coming down onto the little finger, and coming up into T1, which is up in the axilla. Working down the thoracic dermatomes, T4 at the level of the nipples, T10 at the level of the umbilicus, and L1 in the groin.